This video is for educational purposes only and does not replace official training, local protocols, or medical advice. Always follow your specific agency guidelines and medical control. Imagine your body is a giant, bustling city and your blood is a fleet of delivery trucks. These trucks have one crucial job: deliver oxygen and nutrients to every single cell, the houses, so the city can run. Shock happens when the delivery system completely breaks down. It's not about being surprised or scared. In medicine, shock means your organs aren't getting enough oxygen-rich blood to survive. If the delivery trucks stop showing up, the city starts shutting down. The four main types of shock. Think of the circulatory system as a pump, your heart, pipes, your blood vessels, and fluid, your blood. Shock happens when something goes wrong with one of these three things. 1. Hypovolemic shock, the low fluid problem. This happens when there isn't enough fluid in the pipes. Hemorrhagic, caused by massive bleeding, like from a bad car crash or deep cut. Non-hemorrhagic, caused by severe dehydration, like when someone is vomiting or has diarrhea for days and loses all their body fluids. 2. Cardiogenic shock, the broken pump problem. The fluid and pipes are fine, but the pump, the heart, is damaged and can't push the blood forward. This usually happens during a massive heart attack or if the heart suffers trauma. 3. Obstructive shock, the blockage problem. The pump works, but something physical is blocking the pipes, so the blood can't flow. Tension pneumothorax. A popped lung traps air inside the chest, putting so much pressure on the heart that it can't fill up with blood. Cardiac tamponade. Fluid builds up in the sac right around the heart, squeezing it so tightly it can't beat properly. Pulmonary embolism. A massive blood clot gets stuck in the lungs, blocking the delivery trucks from picking up oxygen. 4. Distributive shock, the pipes too wide problem. You have enough fluid, but suddenly all the blood vessels dilate, open up massive and wide. It's like taking the water from a backyard pool and throwing it into the empty ocean. The pressure drops to zero. Anaphylactic shock, a severe allergic reaction, like to a bee sting or peanuts, that makes the blood vessels leak and open up. Septic shock, a massive, overwhelming infection in the blood that causes body-wide inflammation and drops blood pressure. Neurogenic shock, an injury to the spinal cord cuts off the signals from the brain that tell blood vessels to stay tight, causing them to go completely limp. The 3 stages of shock. When shock starts, the body doesn't just give up. It fights back in stages. Stage 1. Compensated shock, the body fights back. The body realizes pressure is dropping, so it kicks into overdrive to save itself. What it looks like: the heart beats super fast, tachycardia, to move blood quicker. The brain tells blood vessels in the skin to squeeze shut to push blood to the core organs: brain, heart, lungs. Because of this, the patient becomes pale, cool, and clammy/sweaty. They might feel anxious or restless. The big clue: the blood pressure is still normal because the body is working hard to hold it up. Stage 2. Decompensated/uncompensated shock, the body tires out. The body can't run a marathon at top speed forever. The defense mechanisms start to fail. What it looks like: the patient becomes confused, sleepy, or hard to wake up because the brain isn't getting enough oxygen. Their breathing gets fast and shallow. The big clue: the blood pressure drops. This is a massive red flag that the body is losing the fight. Stage 3. Irreversible shock, the point of no return. The damage is done. Even if paramedics get the heart pumping or blood pressure back up, the cells and organs have been starved of oxygen for too long and are dying. It leads to total organ failure and ultimately death. How paramedics assess and manage shock in the field. When paramedics arrive, they have to act incredibly fast. They use a strict, rapid system to figure out what's wrong and fix it. The assessment: paramedics look at the shock triad almost instantly. 1. Mental status: is the patient awake and talking normally? If not, the brain is starving. 2. Skin color and temp: is it pale, cold, and sweaty? A sign the body is shunting blood to the core. 3. Pulses: is the pulse super fast and weak? They will also check blood pressure, listen to lung sounds to check for a popped lung or fluid, and look at the story of what happened. Did they crash a bike, eat a peanut, or have a high fever for days? Field management: the fix. Paramedics treat shock based on the specific cause, but a few rules apply to almost everyone. Oxygen, Giving high-flow oxygen ensures whatever blood is moving is packed with as much oxygen as possible. Lay them flat. Keeping the patient flat on their back helps blood flow easily to the brain and heart without having to fight gravity. Keep them warm. Shock messes up the body's thermostat. If a shock patient gets cold, their blood can't clot properly, which makes everything worse. IV fluids. For hypovolemic/distributive paramedics, start intravenous IV lines to pump warm saline fluid directly into the veins to fill the pipes back up and raise blood pressure. Epinephrine. For anaphylaxis if it's a severe allergy, an AP shot instantly squeezes the wide-open pipes shut and opens up the airways. Needle decompression. For obstructive if a popped lung is crushing the heart, a paramedic will slide a specialized needle straight into the chest cavity to let the trapped air escape and relieve the pressure. Rapid transport. Shock is a true time-sensitive emergency. Paramedics do what they can to stabilize the patient, but the ultimate goal is getting them to the flashing lights of the trauma center or emergency room as fast as safely possible. In hemorrhagic shock, severe blood loss, the old school thinking was to pump in as much fluid as possible to get the blood pressure back up to normal. However, modern medicine has completely changed this approach. Today, paramedics use a strategy called permissive hypotension or controlled resuscitation. The goal isn't to make the blood pressure perfect. It's to give just enough fluid to keep the vital organs alive while preventing further harm. Here is exactly how paramedics calculate the amount, rate, and timing in the field. 1. Finding the target. Permissive hypotension. When a patient is bleeding internally, the body tries to clamp down and form blood clots to plug the holes. If a paramedic pumps in too much fluid too fast, two dangerous things happen. 1. Popping the clot. The sudden spike in blood pressure can literally blast away the fragile clots the body just made, causing the patient to bleed even faster. 2. Dilution. IV fluids, like normal saline or lactated ringers, don't carry oxygen and don't help the blood clot. Pumping too much fluid into the body dilutes the remaining real blood, making it harder for the body to stop its own bleeding. The strategy. Paramedics give small fluid bursts to maintain a systolic blood pressure of around 80 to 90 millimeters of mercury, or just enough to feel a weak pulse at the wrist. If the patient is awake and talking to you, their brain is getting enough blood, and their blood pressure is high enough for now. 2. The dosage. Small, measured boluses. Instead of letting an IV bag run wide open indefinitely, paramedics administer fluid in controlled doses called boluses. The amount. A typical adult dose is a 250 to 500 milliliter bolus at a time. The reassessment. After that small amount goes in, the paramedic completely stops the fluid and reassesses the patient. They check. Has the mental status improved? Are they more awake? Has the radial pulse returned or grown stronger? Has the blood pressure hit that 80 to 90 millimeters of mercury sweet spot? The limit, total fluid, is usually capped around 1 to 2 liters in the field. Pushing past this without giving real blood at a hospital significantly increases the risk of complications. 3. Special scenarios. Head injuries. There is one massive exception to the low blood pressure rule: traumatic brain injuries, TBI. If a patient has severe bleeding and a serious head injury, a low blood pressure can be fatal to the brain cells. In these specific cases, paramedics will adjust their strategy to be more aggressive, aiming for a higher systolic blood pressure, usually at least 90 to 110 millimeters of mercury, to ensure the injured brain stays properly perfused with oxygen. 4. The ultimate goal: the stay and play versus load and go balance. Ultimately, no amount of salt water from an IV bag can replace lost blood or fix a ripped artery. Because of this, paramedics minimize their time on the scene. They will often start the IV lines and monitor the fluid rates while moving fast in the back of the ambulance, ensuring the patient gets to a trauma surgeon who can actually stop the bleeding.